Welcome to today's webinar. And again, thank you everyone for your patience with some of the technology challenges that we had bringing everyone in. We appreciate, as always, your time in joining us today for these important sessions. I know I've seen a bunch of you over the past year plus, but by way of introduction for anyone who is new, I am Stacy Villano. I work for the Global Rural Nursing Exchange Network. Our partnership with the University of South Dakota allows us to work together to take these experiences that you're having in your immersion clinics and hospitals and broadcast that to our network of worldwide rural nurses, rural nursing students, educators, and researchers. So that way they can understand this powerful and unique opportunity that's being presented in South Dakota, learn more about how others might be able to bring these opportunities to students and universities around the world, and shine a lens on all of the wonderful work that you're doing, which is critical. As we get started today, we please ask that you keep your microphone muted at all times to prevent feedback and other noises. If you have a question during the Q&A periods, which happens in between each one of our presenter sessions, you can just raise your hand and we will unmute you, or you can unmute yourself. Ask your question. If you would prefer not to ask your questions live, you can always use the chat feature, the Q&A feature, and we'll field that for you. Similarly, please keep your video continuous at all times during the sessions. Given the nature of our discussion today, please do remember to maintain confidentiality at all times. And if you're having a technical issue, because why wouldn't we today, you can feel free to drop that in the chat and we will do our best to get that fixed for you as soon as possible. Keep in mind that in order to support the growth of the ECHO movement, Project ECHO does collect participation data for the TeleECHO program. This is a really great opportunity for Q&A and for discussion and for sharing. So we really hope that you will contribute to the conversation and share your experiences and share your knowledge. So please feel free to do so. We will certainly be opening that up frequently throughout the presentation this morning. It is my pleasure to introduce Dawn Warren, who I know needs no introduction with this group. And I'm going to turn it over now to her to present to you the Healthcare Workforce Development in Rural South Dakota, Telehealth Expansion and Workforce Support.
Well, thank you, everybody. As she said, my name is Dawn. I'm actually in Brookings, South Dakota today for a conference, an AI SDNA conference, and the focus is on AI. And it's so interesting just to hear how all the AI and telemedicine and all these different things that we're doing electronically are really affecting healthcare. So perfect timing. And look at my lights just went out. Gotta love it, right? Okay, I'm going to keep going because I have decided it is definitely a Monday. But so the HRSA grant that USD is a part of, has been blessed to be a part of, is a 3-year grant, $1 million. And it has been a fantastic blessing that we got this grant. We're on our last semester, but right now, but it had multiple parts to it. One part is that we went to the 11 tribal lands in the state of South Dakota. We went to all of them twice a year to really reach out and do a lot of teaching them about healthcare degrees and trying to raise interest in nursing to see if we could get more of the students from the tribal lands into nursing. So that was very rewarding. Another huge part of it that we're talking about today is we had students all across the state of South Dakota who completed a clinical immersion of 11 12-hour shifts, so 132 hours, in small rural hospitals across the state. And so this is a group today of 3 of these students. All of the students are presenting these webinars, but 3 of them today will be talking to you about some of the things that they learned. And then towards the end, we have an expert that's going to talk to us really about some of the things that are happening with telemedicine right now. And it's just perfect timing because, like I say, everything electronic is really booming. So that's kind of the focus of what we're going to be doing here. Okay, next slide. So we are located, for those who may watch us from another country, we're located in the United States. We are in the state of South Dakota. And you can go ahead and go to the next one. So we are a very rural / frontier state, with a lot of rural hospitals, small rural hospitals across the state. Now, there at all of these X's are places that we have had nursing students complete this clinical immersion. And even in the last year, since we developed the slide, there have been a lot more. I even have right now some at a couple of facilities we didn't have last semester. So we have students all over the place. We've had over 100 students do this. What you will see is that up in the upper part of the state, up in the northwest part of the state, really north part of the state, there's very, very little. There's no X's and there's very, very little for healthcare in general. So the farm population, the people who live kind of out in the middle of nowhere have very little resources for them to help with healthcare. But for those who went in some of these other areas, they just really had a really neat experience of learning about how to work with very limited resources. Okay, next slide. So the two main objectives today, the first one, of course, is to hear from the students and about some of the things that they learned about in their small rural hospitals. And the second one is to discuss how telemedicine is used to extend care in rural South Dakota and how providers are trained in it. And then if we have time, a little bit about reimbursement challenges. We have someone from from Avera with us, and I'm very excited to have her speak because she is very up to speed on all the things that are being offered through Avera to these small rural hospitals. Okay, next slide. Okay, so I'm going to go ahead and we'll start with the students. So the first student can go ahead and go on. There we go. Is Allie Schnack. And obviously these are all USD nursing students. And she completed her clinical immersion at Avera Sacred Heart Hospital in Yankton, South Dakota. So Allie, I am going to turn it over to you.
Hi everyone, I'm Allie. I did my immersion experience in Yankton. I got to do kind of a more like specialized route, something that we don't usually see like a lot during just regular nursing school clinicals. So I did pre and post-op and like the PACU. Um, so yeah, I was in Yankton. If you want to go to the next slide. So kind of an overview of the hospital. The first floor is where I worked, where the surgery department was. They also have like their admitting, their lab, some outpatient stuff on the first floor. Their ICU and ER are on the first floor. Um, they have like a second wing of like they have a whole separate surgery center, so like a second surgery like waiting room and a whole other section. So there's two of those. It's still connected to the main hospital, but it's more of their like same day surgery where they have like a lot more of their like GI procedures and some like pain clinic sort of things. That's also on the first floor. Their second floor, they have like women's and children, PT, OT, speech therapy. They have like their sleep center and pastoral care. It's the second floor too. Third floor, they don't really have any patients. They just have like biomed and pharmacy. So no bedside nursing on their third floor. And then at their fourth floor, they have oncology, hematology, and then like an infusion center. And then their fifth floor is just a med surge unit. So I was mainly on that first floor, between the two like surgery sections. So because it was pre, post-op, and PACU, there wasn't a lot of telemedicine, like telehealth stuff that I really saw, but something that I did kind of connect with just like the use of technology was an example with this cardio MEMS device. So basically it's like a monitor that the patient would get implanted, and basically can monitor their like pulmonary artery pressure and send that information like wirelessly to like part of the healthcare team. So they get that done. And basically that wasn't like a big procedure that happened at this hospital. So there was like a representative that came in and basically used like technology too. Like they brought in their little like tablet to kind of educate the like physicians, and then also educating like the patient was educated about like how they could utilize this device that was being implanted in them. So I thought that was really cool. Also, at the other surgery center, there was like a whole separate like waiting room. And so for that, they didn't have a physical person doing like their check-in and everything on that side. So they had like electronic like check-in where the patient could come and check in, and then that would notify like the nurses on that side. So that was like a use of technology too, just kind of utilizing that so that because there wasn't like a physical person over there, that they could just use that technology to help with that. Yeah. A big memorable story that I had, I really just loved the wide like variety of like people that we saw. Like one of my favorite was like a little kiddo that we treated. She was like 8 years old, and she had a bead stuck in her ear, so she had to get that surgically removed. I just loved how like personalized her care was. And like for a typical patient, we wouldn't have the same they wouldn't have the same nurse for like admission for their pre-op and then post-op. But for this little kiddo, we got to like follow her all the way through and do her like help her wake up after surgery and do her PACU stuff too. So that was nice to just kind of get to follow her all the way through and make things like personable. Also, like another thing that they did at this hospital was they did like a lot of like infusion like treatments as well, like outpatients. So I did get to like know some of the patients that would come in for a unit of blood, and then they'd be coming like next week and need like platelets or so on and so forth. So I feel like I really got to get to know like those patients too and kind of see a wide range. I guess the biggest key lesson I learned was I just loved like the atmosphere there and like how important working as a team and like a family is, and how big of a difference that makes. You could really tell like the nurses there were like very like close like on a personal level, and then it just made it that much easier to be like, hey, like I need help with something, like can you help me out? And everybody was just always willing to help. So I just think working as a team is great. So
Awesome. Thank you, Allie. Yeah,
yeah.
common theme that we see with these smaller hospitals, even though Yankton's a little bigger of a smaller hospital, is just kind of the culture of it feels more like a family amongst the nurses and the whole healthcare team, which is great. So if you have questions for now, hang on to them. We're going to keep moving along since we had a little bit of a late start. But thank you, Allie. Okay, next
Thank
slide.
you.
Okay, and now I'm going to turn it over to Maddie. Maddie did her preceptorship or her clinical immersion in the Freeman Regional Health System, which is in Freeman, South Dakota, which is definitely a smaller hospital, and had a really great experience there. So I'm going to turn it over to you, Maddie.
Yeah, so my name is Maddie. Like she said, I did mine in Freeman, and that is a super tiny town. It was about 1,300 people. It's about 50 minutes from Sioux Falls. So they had a 3-bed ER. So there's that room in that picture, and then they had another room that could be used for like any extra room, but also had like all the capabilities for like emergency cares. And then about a 10-bed unit. They have a clinic attached to the hospital and a nursing home. and they can do some outpatient services, like they did some infusions. They also can do swing bed and hospice there. And because it's such a small town and it's far away from Sioux Falls, during like non-operating hours, it sort of acts as an urgent care a little bit. If the patients like have a bloody nose and can't get it stopped, they come in, which would maybe be more so like an urgent care visit than the ER. Or during the day, if they can't get into the clinic, they have to go over to the ER for something. So kind of interesting in that sense. But for the use of telemedicine, they had this system called TytoCare that I saw be used a few times, and it was similar in a way like how we have the iPads for interpreters. It was like an iPad system, and it was used mostly for specialty appointments. So we had a patient who had had pneumonia and had been there for, I don't know, a few days or more, and they used it for an infectious disease visit. And it's interesting because you have like two little devices where you put it up to the patient, and the provider at the other facility can like listen to their heart and lungs. So that was pretty interesting to see, because I was just like, whoa, that's crazy. that is actually works and useful, but super helpful in situations like that where, you know, they either don't have the resources to be transported or drive for those long appointments. And then also in the emergency room, they have this system that's just called the e-emergency. So it's basically like a button on the wall that they can click, and there's either a TV that can go on, or just like a virtual phone connection that they can do to also a provider at the main campus if, say, there was some sort of emergency situation that was a bit over their head or something that they're not familiar treating, and they can kind of confirm cares and plans throughout like the whole emergency situation. So that was pretty cool. I never got to see it used, but that's just an interesting resource for these hospitals that are far out. And for my memorable story, I feel like there was a lot of different memorable experiences there, but I think just one of the biggest things that stuck out to me, because it's small and a much slower pace, being able to spend more one-on-one time with patients was such a huge part of all the care that we gave. Excuse me. The nurse that I worked with, she had been a nurse for like 30 years and was probably one of like the best caregivers I've ever seen, like throughout this whole program. Just the way that she would like get down on the patient's levels, and just, I don't know, absolutely no judgment for any patients that she cared for, was just really, really impressive. And I think it was like my second shift there, I was like hugging patients when I left. It was just a very small town community feel, which was quite refreshing and really nice. Not to dog on the facilities up here at all, but there's just not the time for that. So I feel like that just was really beneficial to see and kind of like remember why we want to be nurses. And then, so with that, my key lessons learned, I think if you've seen any of these other presentations, I feel like a lot of us have gathered, like, to work in rural healthcare, you have to be well-rounded and kind of be a jack of all trades. But I think my biggest lesson was probably just to see how important taking that time and communicating with your patients is. Like, I think we all know that, but to really see it in its best form was really, really special. And yeah, I'll remember it forever.
Thank you, Maddie. Yeah, you know, they always say the nursing is the science, and then the human, the caring part. And it's so nice that in the small rural hospitals, there's more time for the
Yeah.
caring and compassion piece that a lot of us love about nursing. So,
And you could just see like how much of a difference that made with the patients. Like, just the environment between nurses and patients was like so much healthier and like pleasant.
yeah, agree. So excellent. Thank you. You did a great job. Okay, we'll keep moving along here. Next slide, please. Thanks, Maddie. Okay, and now we're going to have Aaliyah talk, Aaliyah Schilling. Aaliyah completed this HRSA grant experience at Avera, Missouri River Health Center. Try and say that fast 3 times. In Gettysburg, South Dakota. and had a great learning experience there too. So I'm happy to turn it over to Aaliyah to talk about what she learned.
Hi, everyone. Like she said, my name's Aaliyah, and I was at Gettysburg, which is like an hour away from my hometown. So it worked out perfectly. Gettysburg is like 1,100 people is around the population of Gettysburg. The hospital and clinic and nursing home are all connected, just like Maddie's hospital was. And that kind of tied into like when patients couldn't get into the clinic, they would just have to come to the ER if it was something that was like super urgent. That picture is of like the clinic lobby, which then like right behind me, like right behind where I was taking the picture is the hospital. So they're just right there. Um, the ER has 3 rooms, and they used one of them as an outpatient room for like infusions, uh, people that would get like shots for chronic illnesses and stuff like that. The med surge has 5 beds, and that was mainly the unit that I was on. Unless there was an ER, then I would go see what's going on. Um, both, oh, I was on both. And the clinic I occasionally went to, which was actually interesting and let me learn that I was not made for the clinic nursing. But in the Gettysburg Hospital, there was 2 nurses usually and 1 tech. And the tech was either a med aid or like a CNA, patient care tech. Um, which sometimes they only had 1 nurse and 1 tech. It just kind of depended on staffing. Use of telemedicine. We also had the EER, which I never saw that be used, but I knew it was there. The telemed appointments, which are like just a little iPad that like walks, like you push around and then the doctor comes on. And I only saw that 1 time, and it was with infectious disease. Um, and then we also used telemedicine for fall risk patients. So there's this big like computer looking thing that is also on wheels, and you just move it around, and then there's like an aide or somebody on the other side of it, like not anywhere close to us, and they are the ones that like watch and make sure that somebody doesn't fall. And if somebody is like a fall risk and they start standing up or trying to get out of bed without somebody there, they will like alert you and like make some loud noise to like alert the staff that there's a person trying to get up. So it's helpful when there's like short staffing or issues like that. My memorable story is patients remembering me from their first day to like their next one. So my HRSA was spread throughout the whole summer. So when I first got there, there were some patients there, and then they would get discharged, and then by the end of the my HRSA grant, I would see the same patients, and it was just nice for them to be like, "Oh, I remember you as a student." So that was fun. And then they also like I also realized that they're just very caring. Like the patients really wanted to know like my personal life, which maybe some people don't want to share, but like also them being so close to home, I was okay with sharing it because they were just these older people that just were bored in the hospital and just wanted to talk. So I liked sharing my story with them. That was nice. And then my key lesson I learned, whoops, sorry. My key lesson is the staff being more welcoming with students, which I think like a lot of the nurses I've had in clinical, they have all been super great. But then I just noticed that in Gettysburg, they were a lot more like, oh, we have a student. And I don't think they really probably get students very often. So they were a lot more like, oh, let's let the student do this. Let's let her see this. Like anything that was going on, it was just nice to like and refreshing for them to be like so excited about a student. So yeah.
Okay. I said it's a technology kind of Monday, isn't it? Because now I lost half my screen. Anyway, fantastic job on that. And yeah, I agree. There is, like we said before, there's just a huge difference with a small rural hospital. Not only the staff being closer and knowing each other well and more of a team family feel, but the patients, because in those small town, they kind of all know each other. So the person that you take care of in the hospital one day might be the person you see in the grocery store a few days later. So it's definitely a different kind of feel. Okay, I think we're going to go ahead and move on to the next one. Okay, perfect. So we're going to move on now to our subject matter expert to talk about telehealth. Okay, next slide. All righty. And I see you on there. Hold on, I lost my big picture. There we go. Okay, Christine. So I'm super glad that it worked out to have Christine join us today. I reached out to Sadaho, who really is kind of one of the big people in the state, organizations in the state that works with a lot of our small rural hospitals and even some of our bigger hospitals. And I said, who do you recommend that I reach out to talk about telemedicine? And they recommended Christine, and she's doing a really lot of great things at Avera Health. And a lot of the students have talked about what Avera is doing in these small little hospitals, how they're connecting to the big Avera Health via telemedicine, et cetera. So I'm going to just turn it over to Christine, and she's going to try and summarize a lot of what they're doing in a short amount of time. So Christine, go ahead.
All right, thanks, Dawn. As Dawn mentioned, my name is Christine Becker. I'm the Director of Virtual Care at Avera. And if you can go to the next slide, that would be great. And so Avera is a health system based out of Sioux Falls, South Dakota, and we have 37 hospitals. It's closer to 250 outpatient clinics, 40 long-term care facilities across our footprint. And this map kind of shows our footprint. We're based in eastern South Dakota, northeastern Nebraska, northwestern Iowa, and southwestern Minnesota. What's really unique about Avera is we are very much rooted in rural healthcare. And out of our 37 hospitals, 35 of those hospitals are critical access hospitals. And critical access hospitals are hospitals that have no more than 25 inpatient beds. And most of our critical access hospitals, I think on average, their average daily census, the number of patients they have, is under 5. And so that is pretty rural and really a unique environment that we're in. And I think the 3 students that you heard today were all at Avera facilities or some of our partner facilities, in kind of varying in size. But since the beginning of time with Avera, and our focus on rural healthcare, we really identified and knew that in order to serve our patients in these rural communities, we had to deliver medicine maybe a little bit differently. And there was really a need for telemedicine. And that need was identified, believe it or not, in the early 1990s when we did our first telemedicine visit. So we've been doing telemedicine for what is that, 30 plus years. So it's not new to Avera, but it was really started as a way to get healthcare to all of these patients across these 72,000 square miles. So if you go to the next slide, this is just a list of some of the telemedicine services that we have at Avera. And as I've mentioned, we rely on telemedicine every single day across every one of our facilities. And I think you heard a couple of examples of how we use telemedicine across Avera. But last year in 2024, we had over 500,000 different patient encounters that involve telemedicine. And so when I say it's used every day, I really mean it's used multiple times every single day, whether it's visits with those telemedicine visits with our infectious disease doctors who are based in Sioux Falls that allow the patient in Freeman or Yankton or Gettysburg to see that infectious disease doctor virtually to get the care that they need. That's one way we use telemedicine, and we call it our specialty care visits. And those were the visits we actually started in the early 1990s. It was those specialists that needed to see patients. There weren't enough of them to go around. We now offer those specialty visits virtually across 37 different specialties at Avera. And we offer them both on the outpatient side, but also the inpatient inpatient side. And when we do these specialty visits on the inpatient side, one of the primary reasons we do them is to allow those patients to stay and get the care that they need locally within their local facility. So that patient in Freeman, South Dakota or Gettysburg, South Dakota doesn't have to be transferred to Sioux Falls. They can stay in their community by their family with the people that they know and get the specialty care that they need. And so that's super important to us and to our patients. But another way we can keep the patients local in their local facility are some of the other services that we offer. Like you heard about the emergency service. That's that service in our emergency departments where there's a big red button on the wall that at any time staff and the local facility can push that red button and be connected to emergency room physicians and nurses in Sioux Falls to be able to get that expertise that they need for a patient that they're trying to support. And so that could be some trauma that they don't see very often, where they just need some guidance and some additional virtual hands to help care for that patient. Or it could be a patient that needs to be transferred to a different facility, and the emergency group can help coordinate that transfer. A lot of the services that we offer via telemedicine were originally started, of course, to help the patients, but originally also to really support the physicians. To provide them with, additional colleagues in some of these small communities. There aren't a lot of physicians. And so if you're called to the emergency room in the middle of the night in Freeman, South Dakota, you are the only physician that's there. But through the emergency service or the specialty care service, for example, or the virtual neurology service, you are connected to experts in those areas that can really help you as a physician kind of care for that patient. But over time, we've really realized that our nursing staff in these facilities also can benefit from a lot of the telehealth services that we offer. And so, for example, one of the services that we offer, and I think this is what I believe it was Aaliyah referenced with the fall risk monitoring, is something we call virtual nursing and virtual monitoring. So we have a hub of folks in our primary tertiary facility here in Sioux Falls, nurses and patient care techs that provide nursing services to some of our rural facilities through the use of telehealth. And so these services include monitoring patients who are at high risk of falling. And Dawn mentioned she's at a conference about AI. Well, those services that we use for virtual monitoring use AI to help with that service. So our virtual monitor can be monitoring 30 patients across our 72,000, square miles of footprint. They can be monitoring 30 different patients who are at high risk of falling with the help of AI. And the AI is computer vision that is sort of watching the patients and watching for the patients to see if they're moving in such a way that they might be at risk of falling. Are they starting to sit up in bed, maybe swing their legs over the edge of the bed, start to stand up? And if they are, that AI will notify the virtual monitor. So the virtual monitor can notify the local staff, can redirect the patient by coming virtually on their TV screen or audio saying, hey, patient, get back into bed. We'll get a nurse in to help you, something like that, all to prevent patients from falling. So virtual monitoring is one way we help support our nurses, but we also do a lot of virtual nursing as well. And virtual nursing is really a service where our nurses are sitting remotely, helping nurses in local facilities with things like documentation, doing different types of assessments, doing double checks for medications or blood administration, for example. And they also do some mentoring and provide nursing expertise services to really help those local nurses. And the whole reason we're doing this, of course, is to help care for those patients in those rural facilities. So I could literally talk for hours about all of these virtual services that we offer across Avera, but those are some of the highlights that I wanted to mention today, but all of them are important to us, and being really able to use technology in different ways to care for our patients, especially those patients in rural areas that just don't have access to the specialists or the different types of services that a large community might offer.
Excellent, Christine. Thank you so much.
Mhm.
I honestly have just been kind of blown away in these last couple of months learning how much telemedicine is doing. I mean, when you just look at this list of everything that Avera is doing, and then just going around to visit students at these small rural hospitals and seeing all these monitors, and like you just said, even having another nurse connect with you so you can give blood, right? What if you're the only RN on the shift? Things that you would not normally think of that really opens up the field for what you can care for as opposed to having to send these people to a to a bigger city. So huge, huge benefits to all of this. I would like to ask the students who did not do this HRSA grant, who are not in a small rural hospital, what telemedicine things have you seen in your clinicals, or have you seen much in the bigger hospitals? Has anyone give us an example of things that you've seen? I mean, as a whole, I wouldn't think there's not as much in the bigger hospitals, but Christine might be able to tell me otherwise. Have any of you who've just done clinicals at like just Avera, Sanford, the bigger hospitals, seen any specific use of telemedicine? I'm looking at a few of you now. Online translation resources. Oh, that's a really good one. Yeah. Oh, and Carissa, admissions. Okay. Yeah, they were talking about that here at this conference with admissions, even AI helping with admissions. And of course, there's a lot of work to be done on this. Because there's always like a little bit of a worry, like is something going to get missed? But and virtual monitor for fall risks. Okay. So Lindsay, where were you at where they used the virtual monitoring for the fall risks, the patients who are at risk for falls?
I was at Avera in Sioux Falls on the renal unit.
Okay, so there's a perfect example of using it even in a big hospital, but you could save on staffing in a sense because you have somebody at the remote location, like Christine was talking about, and AI to help that can kind of look at multiple things as opposed to having someone like sit in the room with them. So that's a great one. Okay, Avera, Hannah said Avera McKinnon ED in Sioux Falls. Oh, it went away. I got to go back to my chat here. Let's see. Pull up Avel. Yep, emergency, simply to have a nurse chart. Yeah, during an high acuity situation. And I've heard of that a lot in these small rural hospitals too. Like if a trauma patient comes in or a cardiac patient, and the one or two nurses you have is doing all this stuff, having someone just there on the screen that can do all your documentation for you. So that's a great one, Hannah. Sydney, I've seen virtual monitoring as well at Stanford on the surgical trauma unit. Okay. Sydney, can you talk about that? What did you see?
So on the surgical trauma unit, they had like the closer rooms towards like the nursing stations would be like the ones with the monitors, just for like high risk patients for falls or like the more critical patients.
Perfect. Great example. Okay. And then I'm just looking up here. Central line, Julia, how did the virtual part work with central line checks then? Can you explain how they did that one?
Yeah, I'm on the oncology unit at Avera, and they just have a nurse kind of chime in through the TV, and they just like look at the central line, make sure the date is correct. They watch them do like a CHG bath if they haven't done one yet. And yeah, so it's really cool.
So this is probably a silly question, but I assume that with the TV thing, they can really zoom it in so they can see it close. Like if you have a central line right here, they zoom it in so they can see it close, like if
Yeah,
there's signs
you
of
can like
infection and stuff.
see how they like zoom into like they kind of just they
Okay.
zoom in and like they can like look at like the whole area. Sometimes you have to help like move their gown and stuff, but
Sure.
most of the
Okay.
time they can like see the whole thing.
Okay. Oh my gosh. Yeah. So cool, isn't it? Um, Carissa, will you talk about where did you see the admissions stuff done?
I also saw it on the oncology unit, and you just kind of during the day, especially, they just do all the admission questions, and then they also can be like the second nurse for skin checks, I think. I think. And then they also can do discharge education.
Wow. Okay. Yeah, we had discussion here at this conference actually about discharge because there are some hospitals that are trialing using AI to help with discharge. And of course, there's ethical, there's concerns because it's like, gosh, could something get, misunderstood? Or there's just always concerns with a big change like this to making sure you don't miss something or something isn't incorrect. But it's really exciting to see all the things that are happening and just know with anything new, it's going to take some time, right, to figure out some of these little details of some of the things that aren't perfected yet. Um, and they really have been talking about just you can't take for nurses not to worry because telemedicine will never replace a nurse because you can't replace the human caring compassion side of things. But we just have to make sure we don't let some of the tele stuff take over that and the AI stuff take over that. Other examples of telemedicine things you've seen? Now, you guys are probably in different parts. Are any of you in fourth? I know some silly questions. Some of you are in fourth semester. So is this what I'm seeing on here, this e-sane, is that the sexual assault response? Is that what that is?
Yep, that is what that is. And that's a service that we offer. So if a patient was sexually assaulted and goes to an emergency room somewhere, they likely don't have sane nurses there. And so through the use of technology, the sane nurses in one of our facilities can kind of join them, do the exam remotely, make sure all the documentation is correct and everything that's needed for those services, just to make sure that, everything that needs to be captured is captured in the right way. They do all the kind of the detailed kind of work around all of that. So, it's a service that it's unfortunate that we have to have, but I'm very grateful that we have it because when it's needed, it's so valuable to have that.
Yeah, that's huge. Do you guys in fourth semester, do you still do the same training as part of 471 or maybe in a different course, did you? And I can't see you all, so I'd love to hear voices. Okay, I'm not hearing anything, so maybe not. I don't know. But it takes there's a specialized training to be certified to take care of patients who've been sexually assaulted. That's the ideal is that you have somebody who has. So what a blessing. Yeah, if you're out in the middle of nowhere in a small rural place and someone gets sexually assaulted, to have somebody who knows how to talk to them, knows the things that need to happen because it's a very hard, difficult time for obviously the person who's been assaulted. Okay, let's see. Sydney, virtual monitor. Okay, that's the surgical trauma unit. Okay, other thoughts or other things that you guys have seen? We have a couple minutes left here. Would you talk briefly, Christine, about the behavioral health? Because I will say that on some of these visits that I've done to see students in rural, I have heard a lot of people say that patients came in like with a mental health crisis and, maybe had a nurse practitioner on, who's just kind of family medicine type stuff, and they really needed a mental health specialist. I've heard this a number of times. And so they connected with
Yeah.
virtually. Will you talk about that?
Yeah, so one of the services that we offer, and we offer what you described through our partnership with Avel, is what we call e-behavioral health. So if a patient presents to an emergency room or they're an inpatient and they're having some kind of behavioral health crisis, we can use this service to pull in a behavioral health specialist to really help triage, assess, and care for this patient. And so that is especially helpful in some of these smaller rural communities where they may not have that expertise or even the time to be able to kind of help this patient and get them to the right care that they need. So that's a service that we offer across most of our acute facilities. We also do a lot of telehealth visits with behavioral health providers, within Avera as well. And so these are mostly outpatient type visits, either where the patient presents to one of our facilities and does these visits, or potentially the patient is at home and we do these visits as well. And so, that's just super important. Behavioral health care is of course important, but these behavioral health providers, we just don't have enough of them to go around. And so the better access we can give to our patients to make it easy for them to get this care is super important. Another thing that happens in South Dakota, now this isn't through Avera, it's mostly through the state and through Avel Healthcare, but they actually have some of these behavioral health crisis services in the back of police cars and state troopers. So if the patient, is being, sort of seen by the state trooper or our police, they can access these behavioral health care providers right where they are, wherever it is, through the technology in their car. And so that's super cool too.
Yeah, I'm so glad you brought that up, Christine, because I have heard that in many communities too, that the police officers are oftentimes the mental health people in these
Correct.
small communities, because that's all there is.
Mm-hmm.
So yeah, fascinating, just absolutely fascinating to me. Okay. Is there questions for the students who presented if you don't have anything else for Christine? I guess I would just say for any of you those of you, the students that presented, if you had a takeaway message for the students who are considering, like, if they want to work in a big hospital, small hospital, what do you think was the biggest advantage to working in a small rural facility for those of you who spoke today?
I think for being a student who's still learning, the slower pace was really nice. I feel like a less stressful environment to try to learn. So I appreciated that.
Yeah, anybody would, right? That's great. Thanks, Maddie.
I kind of mentioned this before, just like the tight, like close-knit community is just really nice, like working rurally. And everybody knows that you have each other's backs. So
Yeah.
it's nice.
That's huge in life, period, right? Have each other's back.
Yeah.
Great one.
I would say like what I said, my key lesson were just like the nurses being so welcoming was my big takeaway.
Well, I'm a champion of small rural hospitals. That's what I did as a new graduate. I actually worked in Del Rapids by Sioux Falls for first year. Absolutely loved it. You really do a little bit of everything. And then after a year, I was ready for something big. So I moved and went but after that year, I kind of knew all because I'd done kind of a little bit of everything. So anyway, something to consider. And even if you don't go as a new grad and you want to do, a bigger hospital, a lot of people started bigger, and then after a couple of years, they're ready for something smaller where it's more of a family feel. So something to keep in mind. But I think it'll be fun to see what happens as we go along here with telemedicine and AI. I am going to turn over to you, Stacy, because I think we are about out of time.
There we go. Thank you, everyone, for participating today, to our presenters, for sharing all of that incredible information. I am going to drop in the chat the survey link that precedes our time together today. If you could take just a quick moment to click on the link and share your input, we would really, really appreciate it. This goes a long way into helping us. It is not letting me. I'm telling you, it is definitely.
It is a Monday.
I think it's technology just blowing up on us today as we have this, telehealth session. What is happening here? Okay, here we go. There you go. There's your link. Surveys are so important. They really help us plan for future. We are grateful for your time today. We will be archiving this session for on demand on the GRNEN website within the next few days. If you want to reference back to anything or share this presentation with somebody who you think would find value in it, we would be grateful. So have a wonderful rest of your day, everyone, and we look forward to seeing you at our next talk. Take care.
Thank you, everybody. Bye-bye.